Now, the structures in the sphenoid model, this is what we need to check for. So, as I mentioned, that your third patty of nasal packing should go medially between the middle turbinate and the septum. So, don't try to push this patty from here again. While doing this, see, this lateral movement of the anterior part may happen and you may encounter the fracture in the skull vessel. So, while putting this party, go behind and pack it here. So, slowly if you pack it here, so I am creating my space there. It's very nice cadaver. So, thank you Prashant sir, it's an excellent embalming and superb. I am enjoying the life of doing things that you do. I made surgery, but still the feel of this tissue is superb. So, for the third part, you go again at the posterior end of the middle turbinate. For the second thing, we slide the scope laterally and enter the middle meatus. Similarly, going at the posterior end here and slide your scope medially and see what you are seeing above. See that swivel of the tissue is your superior turbinate, and again it is coming from the skull base. It's a superior attachment is to the plana, and if you slide your scope posteriorly,
complain of post-nasal drip after surgery. And what sir is showing, this is the medial approach to the sphenoid sinus ostium. And as I had said in the morning, it is around 1.5 centimeters above the nasopharynx.
Another important thing, most of the time you encounter the patients with undiagnosed headache, long-standing headache, and it's a typical of occipital headache, and in these patients most of the time you may come across the isolated sphenoid sinus pathology. So there is a small polyp in this area obstructing the sphenoid os, or you may encounter the pus draining from the sphenoid, and if you ask for the CT scan, you will find there is only a pathology, or even in allergic fungal sinusitis cases of allergic fungal sinusitis, in early phases, the disease starts in the sphenoid sinus and it expands there, involves the posterior ethmoid cells, and these patients typically see this look of the nasal cavity is absolutely normal. Patient only complaint is the thick cast coming in the throat, and if you check here, you may find a thick mucin coming out from the sphenoid sinus. And in these cases, the important investigation you need to go for is a CT pattern sinus, where you can come across the pathology model. So the third part is basically to assess the sphenoid disease, the superior turbinate, the sphenoid os, and is there any pus draining from this or polyp from this area. See, when I do this, my anterior part of the middle turbinate is not at all touched. So in all these passes, this first pass, slide laterally, coming anteriorly, I am checking the anterior middle turbinate, bulla, hiatus semilunar is middle meatus, accessory ostium, going back again, slide medially and assess the sphenoid model. This simple, it's hardly take 3 minutes when you are used to it. But as I mentioned, these are the list of the things you need to go for the checking your diagnostic nasal endoscopy, and that all these things need to be enumerated and checked and calculated in your diagnostic nasal endoscopy report when you do the diagnostic nasal endoscopy for your OPD patient.
I think the take-home message is go posterior to anterior rather than anterior to posterior.
Yeah, never try to introduce the scope. That is the most important thing in the middle ear. Always go at the posterior of the middle turbinate, slide it, and it is very easy manual. See, slide it laterally, you are in the middle meatus, slide it immediately, you are in the superior meatus or sphenoid model disease. This happens.
As Satin told you, that it is important to do diagnostic in all the cases, including DCR, because in DCR it is very rare, but what we see sometimes in the inferior meatus, you have a lesion, you have foreign body, a small hemangioma, that is causing natural cystitis. And if you diagnose that, then obviously you don't have to do a DCR. You just clear that lesion and just wait for a few months.
So now we proceed with the basic steps of the phase. The most anterior surgery what you do in the nasal cavity is a PCR. But sir will do this in the last, because that may disturb this the anatomy of the upper end of the uncinate process and everything. So we will go for the first the basic phase steps, and then we come and do the TCR in the last. So, as I mentioned, there are 4 lamellae. What you come across from the anterior end to the going for the basic steps of the phase. So tomorrow we will be having the live surgical section where we will discuss about the nasal packing, the infiltration, and all these questions will be answered while we are preparing the notes for the surgery. So today we utilize the maximum as we got such a nice cadaver, हात शिवशिवने म्हणतात तसं माझ्या हाताला व्हायला go for this dissection. So the first step in your functional endoscopic sinus surgery is the identifying the landmarks. Most important landmarks in your surgery, first is the lateral wall, this is your the inferior turbinate, which is the most constant landmark, but sometimes when you are encountering with the nasal tumors, large nasal tumors, this may be destroyed and you may find the pathology coming till the anterior. Or in some cases where there is extensive polyposis, where the polyps are extending till the anterior vestibule, so you may not find this landmark. So the first thing what you need to do is define this first landmark from anterior to the posterior end. It's not only the halfway you are done it and go ahead. See, always you should have in vision the full extent of the nasal floor before going for any face surgery. So good proper decongestion is required. Then next thing, just slowly see what I am doing. Just pressing the back side of my inferior crest elevator. I am pushing the inferior turbinate laterally. So with this you are creating this sort of inferior corridor. So all the time it's so easy to pass my scope along the floor, do the suctioning, and I always correlate with this posterior choana, the superior border of the posterior choana and relationship to these structures. So the first landmark and most important is define the inferior turbinate from anterior to the posterior end. Then slowly lateralize the inferior turbinate and creating the inferior corridor for your suction. See, the most important thing about the face surgery is small steps in this demonstration. See, all the time, look at my instrument and my scope movements. See, this distance is constant. As I move my instrument, my scope is going in, and this has happened with the habit. But you need to develop this kind of habit. See, usually what you do to put the scope like this, put the instrument here, then go in, then go in. So always that may fog your scope in between. So if I go all along, see, none of the structure coming in my way, and I can create my way in the nasal cavity. So that is the most important practical points.
I think this was mentioned by Dr. Sandeep also in today's lecture about complications. That the hand-eye coordination should be proper, the coordination between both your hands. It only comes with practice. Always make sure that the instrument is just ahead of the scope and your scope is not ahead of the instrument. Otherwise you will end up blindly injuring some structure.
So next thing in creating a corridor is tackling the medial wall as your nasal septum. See, if there is too much of the anterior septal deviation, you may need to go in for the septoplasty procedure, do the septoplasty, create a space here, and then go for the middle meanders or the nasal work. Or if you don't want to go for the septoplasty, like in doing the DCR surgery, you want to create a space here, just go along the maxillary crest and the bony septa and slowly try to fracture it. See, you can hear this crackle. Okay, so with fracturing this, so you just slowly fracture this nasal septum and see I have created space here. So the most important step of your nasal surgery is creating a room for you so that there will be a less damage to this anterior part of the nasal mucosa. Because if you damage this anterior part of the nasal mucosa, there are very high chances of sinus formation, and which is the most important thing in your failure of the of your surgical outcome, because this syndicate hinder the ventilation of the nasal cavity, which is the key target of your nasal surgery in all these procedures. The next thing, after lateralizing the inferior turbinate, after creating this space by mobilizing the septum, the next thing what you need to go for medialization of the middle turbinate. And again, remember the important anatomy. It's going to the skull base, and if you damage, see the mobility is limited. But you need to do slowly. So what you do, the back surface of your flares elevator, go in slowly and slowly try to push it against the septum. See here you see here the small crackle, that the fracture of this bone, and slide your flares elevator. See this movement. See my movement. I am not going here and pushing it. See, I am going at the junction of superior 1/3 and inferior or halfway, and just try to push this bulge medially, and creating this space in the middle meatus. See, at this stage, if you feel that the middle turbinate is too much mobile, then a simple manual you can go in for putting the small patty here, backing position. Simple thing what you can do, put one patty at the posterior, that the oblique part of the middle turbinate here. I'll just show you. Simply, if you put one patty here, okay, so that will go, so that doesn't come. See now the space. See here space. Earlier it was like this. Now I want more space. I can slide this flat little and clearly see more space created. I can see now the upper end of the uncinate process till the lower end. Right? So after creating this space, when we talk about the basic steps of the face, so you encounter 4 different lamella, as I mentioned earlier. The first one is the uncinate process. The next is anterior face of the concha bullosa. Then the basal lamella, and then fourth is the anterior face of the sphenoid sinus. So the first important step to start with is the uncinectomy, so that the encountering and handling your first lamella to enter the anatomy of the lateral nasal wall. So this uncinate, as I mentioned earlier, 3 attachments. This vertical part going, either it may go attach the lamella papillaris here, it may go to the skull base, or it may turn and attach the middle turbinate. And this attachments you need to assess on your CT paranasal sinus, and accordingly the anatomy of the frontal sinus drainage pathway changes for all these 3 attachments. And see, this is the groove. This is called where the uncinate process, the anterior end of the uncinate ends here, and that's my area, this soft area area, that is my anterior fontanelle, and that's my posterior fontanelle area. So for going for the uncinectomy, there are different techniques mentioned. Initially, they used to use sickle. So either you use with the sickle line, back line. So see, that's my lateral attachment of the uncinate process. So you may go in here with the sickle line, take this incision, elevate the vertical part of the uncinate process and take it off. But see, when I do this uncinectomy, I will show you this attachment, and I prefer not to go for this technique because there are very high chances of entering into the orbit by damaging your lamina papyracea laterally. So why, when I do this vertical portion, so instead I prefer to do it the other way, the flat floor technique. So where, see, this is my ball probe, this is the instrument you are supposed to use it for this step. Just slide your ball probe at the free edge of the uncinate. See this, how this uncinate is moving, and slowly try to see again, see here, see the movement, and you feel the crackle. Every crackle, there is a small fractures you are creating. So this, I am creating the space, and my ball probe is in the from the hiatus semilunaris to the infundibulum. See this, it's going in. That's my natural ops there. Okay. So this uncinate, the vertical and the horizontal segment of the uncinate is creating this three-dimensional space labeled as infundibulum, and which opens through this hiatus semilunaris. So the first step of the uncinectomy is medializing the uncinate and just mobilizing this vertical part of the uncinate. I have not done anything through my horizontal process. This is my horizontal process. The next instrument I will go for, this is a backbiting punch, the ostrum backbiting punch. So this comes either it's a rotatable or it may be after, and you need to handle with your elbow movements by either doing it for the right side or for the left side. So that you can handle with your elbow movement if it is from this after. So this next instrument, after mobilizing the uncinate, I will go for creating something called as a window, the Parsons window, and it is created at the junction of the upper vertical portion and the horizontal portion. See how I am introducing my backbiting punch. That is again important. Look at the hand movements. The movements are happening at my elbow level. So I am going in at the level of my this oblique or basal lamella of the middle turbinate, or oblique part of the middle turbinate. I am just sliding and pushing and creating space here by pushing here, and then try to open my punch, slowly coming forward at the junction of superior. Now at this stage, I slide my elbow coming closer and this keep going lateral. See this. This is my full engagement of the ostrum punch and just a punch. Then again staying there, I open it, move it little anteriorly and take the second punch. Yeah, very good question. So, see, we are having the accessory ostium there. What is asking if whether we can enter the accessory ostium and connecting that thing. So that is the most simple way of opening the maxillary os. So you enter the accessory ostium and come forward, and you will encounter in opening the maxillary. So maxillary endoscopy will be done in simply even by doing the diagnostic nasal endoscopy. If your patient is little cooperative, you can do that thing as an OPD procedure. Here I am not doing that thing because I want to show, if possible, the accessory ostium and the natural ostium and the relation to that. So my first backbiter cut I done. Then again I engage my punch and I come. See, while coming and this way, always try to go downward rather than coming and anteriorly, because if you come anteriorly, there are chances of damaging the important structure there which runs from downwards and opens in the medial meander, that is your nasal lacrimal duct. So to avoid traumatizing the nasal lacrimal duct, after this my first bite, I try to rotate my punch little downward and move forward and take my second touch. So normally 1.5 to 2 cuts are adequate for creating this partial window. After creating this window, see the anatomy. Yeah, I am not mobilizing, I just show you the second. This is the magic of these two instruments. The way these instruments cuts, they are like sliding a knife on the butter. Usually Indian make instrument you won't get that finesse. So this window, see, I just want to show you what we talk about see the anatomy. That's your infundibulum and that's the maxillary ostium. Today you need not to go this, I just want to show you the anatomy of the infundibulum. So see, with the 70 degree I just going in, so see that's still the horizontal uncinate process, okay, and that's the area, that's the 3-dimensional structure there, that's the vertical uncinate, that's the horizontal uncinate, and this is the maxillary ostium, the maxillary process of the inferior turbinate little bit and the horizontal uncinate still, and that's your opening of the maxillary ostium. So again back to the 0 degree. So all you are doing, see, at this stage you need not go for the 70 degree. So these things I just for the demonstration purpose I taken this. So we are still with the 0 degree. Okay. So the next thing, after backbiting, see what is called as swing turn technique, what you are talking about the uncinectomy. So now this will become my swing toe. See this. See. And it hinged at this attachment top. So I am very safe, there is least chances of the entering into the orbit. See, at this stage, this is my horizontal process, see this, and the most important instrument, the power instrument you need to have now is become the necessity in the functional endoscopic sinus surgery is the microdebrider. But as so as you are junior in the first year or first 2-3 years of the practice, you may not be having a micro debrider. So I will show you the step. See, that's a 45 through cut. I am just taking this cut here, and then second cut here, and I am taking out this. See, so I had removed only the lower half of the uncinate process. So that's the bone of the uncinate process. See this bone, this curve bone. See this. The pin bone.
Another important point here is sir used the cut because he was not using the micro debrider. Never use the Lexley in this case because what happens is Lexley will pull the mucosa.
Yeah.
And it will cause bleeding, and again you may injure something which is behind it. So rather cut it through rather than pull it.
Now see, that's my maxillary ostium here, already in the vision. Again, similarly for the horizontal process, you need to take one cut here, one cut here, and you can complete the maxillary antrostomy. But with the advent of these powered instruments, we can go in for removing the mucosa in very precise way. So this is a micro debrider. See, there are two plates here. Okay, so inner plate rotates and there is a suction pole. So what it does, it sucks the mucosa in, and with the contact with the outer plate, it cuts the mucosa in a very sharp way. I think it's possible. See, now I go for this horizontal process of the. See, now what you are talking about, why not go in the accessory ostium? See, now you can make out, this is my accessory ostium, that's the level of the natural ostium. See this distance. Okay, that's a horizontal horizontal process of the uncinate process. So what that wall mechanism happening here in the sinusitis, why there is this accessory ostium. There is an open drainage pathway, but still this maxillary sinus is not draining to the accessory ostium, but is dry because of the direction of the mucocilia, which are directing the mucus towards the natural ostium. So it's the most important factor. So what Professor Stamberger says, the simplest procedure when you encounter this and only the maxillary sinus disease, the simplest procedure what you do, introduce your backbiting punch in the accessory ostium and just come anteriorly and join this natural ostium with this. That's all. This is much is sufficient. But widen this ostium and go for taking this horizontal uncinate process and the lateral mucosa of the maxillary sinus and the medial mucosa over the horizontal uncinate. So I am removing and taking this sharp mucosal cuts.
Hello, sir.
Yes.
One question. We often say that every organ in the body is important, critical. Somewhere there is some function associated with it. There is this accessory ostium. We say it has no function because usually the mucus drains through ciliary action to the natural ostium. Is there any study or is there any idea about what could be the reason why God has given this accessory ostium? Any study regarding any role this accessory ostium is having?
See, the most important pathology associated with this accessory ostium is basically it's a area which are deficit of the bone, and because of chronic sinusitis, what happens there mucosa dehiscence, and that like our central perforation, it fails to fuse and forms the accessory ostium. And Professor Stamberger, the basic techniques of the functional endoscopic surgery, the principles is based on the drainage pathway of the maxillary sinus or any sinus, and it is directed to the natural ostia. And from there, the concept of preserving the mucosa as much as possible, because that is a ciliary mucosa which is helpful in the drainage of the sinus. And while doing the sinus surgery, instead of going for just wide debridement, or earlier we used to plug the tissue, instead of going that, creating the openings in the sinus which widens the natural ostium as much as possible, so that ventilates the sinus, and at the same time as you mentioned, there must be function. Instead, the accessory ostia helps in the pathology of the sinus, chronic sinusitis. Acute sinusitis, it happens, there will be a formation of the accessory ostia, and this may cause, because there is one theory mentions that the first draining from the accessory ostium, or rather coming from the natural ostium, the mucus goes in and re-enters the sinus through the accessory ostium, and this circular movement may cause the stagnation of the secretion and secondary infection.
I think we covered this in the morning lectures. What happens is there are certain areas anterior and posterior to the uncinate process where there is deficiency of bone. They are only covered with a double layer of mucosa. And whenever there is an absence of those mucosa, that is give rise to accessory ostia. And those deficiencies in bones are the spontaneous.
Or is it something like a room that always does have, not just have a door, it will have a window for cross ventilation? Is there something physiological wherein these two ostia are complementing each other in ventilation of the sinus?
They may not be present in all cases. A lot of the times it is covered by mucosa. You may not encounter an accessory ostia in all cases. So it is difficult to define whether they are complementing each other. I think what you will see is a lot of the time the AC volume comes out through the accessory ostia.
Yeah. Okay, Milind sir, anything you like to add?
The accessory ostium as such does not have a function, but what happens is, because the mucociliary transport is toward the natural ostium, with the accessory ostium there, it forms a loop of secretion which goes around. So in spite of having an accessory ostium, you still have sinusitis, because the secretion which are coming out would again enter through the accessory ostium in the maxillary sinus. So it is very important to connect the two and make one point.
Yeah, another important thing, see, after making this partial window, most of the time it has been thought that just fracture the horizontal labella of the uncinate medially. See, what happens while doing this fracturing, you may pull this. See, I already done the uncinectomy, but still that small tendon, if I pull this, see what is happening. See the mucosa here, and there are very high chances that you may strip off this part of the maxillary sinus mucosa, which is a normal mucosa and which is against your principles of the maxillary, the functional endoscopic sinus surgery. So to avoid this stripping of this mucosa, you need to either take a sharp cut here, and then with the Tetraslate take out this piece of of the horizontal unsafe process, or the best way is going in with the microdebrider and cutting the mucosa sharp. Now next thing about the size of the maxillary ostium, how much it needs to be wider. There are lot many studies, but majority says that the size of ostium doesn't matter. The most important thing, it should not get stenosed. And as you see here, at all the places, my medial mucosa meets the lateral mucosa. See here, medial mucosa meets the lateral mucosa, and while healing it doesn't close because there is a law of contact inhibition. This mucosa end, there is no raw area, and it will give nice wide maxillary endoscopy. And with the 0 degree C, I can see the interior of the maxillary sinus. If I go for the 70 degree, I can check for any pathology on the lateral wall or the anterior wall. Is there any polyp arising from there, or any inflammatory mucosa there? So see.
So how exactly will you define a wide endoscopy? How will you define the term wide?
See, wide, that is what I say, the size, the pathology is important when you are going for the maxillary endoscopy. If you are doing it for the simple sinusitis procedure, so this much what I created now is adequate. If you are doing it for the allergic fungal sinusitis, definitely you need to compromise. See, this lower part of the middle meanders is the maxillary process of inferior turbinate bone. So I am with the 70 degree, I am looking on the lateral wall, so that's my inferior. See, when I move this bone, you see the movement, and whatever movement you are seeing, that's the maxillary process of the inferior turbinate. So with the downrighting maxillary punch, downrighting maxillary punch, or give it backward, give it backward. See, there is one instrument comes as a maxillary punch, or even with the backfighter, you can go in and just come down and remove this bone. It's a little bit thick bone of the. I am going with the 70 degree. I don't want to change. So this is wide. So this is extended wide, you can say. So if you are doing it for the allergic fungal sinusitis, they say sometimes go till the floor of the maxillary sinus so that your pushing is served well. So that pushing solution enters the maxillary sinus and drains out the mucin, which is most important pathological factor in formation of your polyp rather than the fungal wall. That mucin comes in contact with the mucosa and causes the allergic reaction. And so I am going in with the 70 degree. See, again 70 degree scope requires some hand manipulation and the practice. See how I am doing. Now when I am introducing, it's used similar like a 0 degree, but I see the angulation of my scope. I am going, and when I try to look in the, so I am moving my scope like this, and see, I can see the interior of the roof, that's the lateral wall, here the anterior wall, and if I take a little more, here I can see the anterior part of the. So there are some extended procedures, like when you are going for the maxillary artery clamping in your angiofibroma procedures, or some inverted papilloma cases where the pathology has extended till the lateral wall, and you want, and also the disease has come anteriorly. In those cases, the extended medial maxillectomy, endoscopic medial maxillectomy, you can go and come anteriorly, or even you can go for the modified Denkers. In the last we will demonstrate the modified Denkers, and see most of the people have seen those things during the era of your COVID mucormycosis. So have wide opening of the, in those cases you may go for this modified Leclerc's procedure. So for the isolated maxillary sinus disease, what we had done, see here, the most important thing I had done, I had reserved this superior half of the vertical portion of the uncinate process, and this is for only the isolated maxillary sinus disease. I am not touching anything, and while doing this, the most important thing, don't damage the mucosa on the lateral surface of the middle terminal. That's an important thing in formation of this anterior sinus. You see, here is the raw area. If you damage this part of the maxillary lateral surface of the middle terminal, there may be high chances of synechial formation, and always whenever there is a synechial, contracts and pull my turbinate like this, and there is a stenosis or hindrance to the ventilation of the maxillary sinus. Then that may be the causes of failure of your sinus surgery.
Again, we discussed this in the morning that at any point don't let an adhesion happen between the septum and the inferior turbinate, and between the middle turbinate and the lateral nasal wall. So sir is just reinforcing that. Sir, what will be your anterior limit of widening?
See, this is my lateral crust or the lacrimal crust. If you extend this lacrimal crust down, see my nasolacrimal duct, it runs approximately 1 or 2 millimeter anterior to the lacrimal crust and coming like this. So this may be the pathway of my nasolacrimal duct. So it should not come too anteriorly crossing your lacrimal crust area. So in some cases they mention about the pre-lacrimal approach, where they take the incision at a piriform aperture, elevate this flap, remove or drill out the anteriormost part of the maxillary sinus, and you can band on see the interior of the maxillary sinus, clear the disease, deflect this flap. So here your lacrimal apparatus is well preserved. You are not touching anything to the lacrimal apparatus. You are widened the thing. You can put the scope from here and the instrument from the anterior port, or other way around, and you can handle the disease in the anteriormost part of the maxillary sinus. Or sometimes you may go from the upper gingiva with the trocar in the canine fossa. And not to the skin, from the upper gingivobuccal sulcus in the canine fossa, make a trocar hole of 4 mm, put the trocar in, and through that you can put the scope or your debrider blade and address the disease. Here you use the 70 degree.
So basically that is where we take the cardiologist.
Not exactly calculus, because in calculus you are removing the white thing, but here it is called the visualization of instrumentation in the anteriormost part of the maxillary sinus. So these are different approaches.
I think the pre-lacrimal approach, I think I have seen Professor P.J. Mormon use it for inverted papilloma surgery.
Yes, so complete disease clearance, but the biggest disadvantage with the pre-lacrimal approach is, see, you do it, remove the disease, and then you suture this flap back. So for the surveillance thing, again from this vision, so again the anteriormost part of the recess is not under surveillance. So whether your leftover disease or the recurrent disease, so instead in those cases, if you are gone for the modified Leclerc's procedure, where you compromise the inferior turbinate and open the maxilla wide open, and you can easily with the 0 degree you can see the lateral wall, the anteriormost wall of the maxilla. For this surveillance procedure, they say it's best to go for the modified Leclerc's rather than going with this pre-lacrimal approach. Or the advantage of this is this maintains the anterior anatomy well, and your
Sir, how about the inferior meatus? We can put the instrument to the, just like the old time endoscopy.
Inferior meatus endoscopy.
No, inferior meatus endoscopy and putting the scope or debrider through that opening. So I say the lateral wall of the.
See the beauty of when if you put the canine fossa approach with the trocar, rather you are saying going from here and you just go in this way and you just
Yes, absolutely.
yeah. But what happens with this approach? See, this is my trocar. I am going. I just make the what happens if I go in this bone with ears, but most of the time you may have the residual inferior meatus endoscopy here, and again that goes in the principle. See, this is made in the inferior meatus, from where you can introduce the cadaveric sinus. Visualize the anterior part of the thing, but it may leave back the inferior meatus endoscopy, and again it will serve like your accessory ostium. So rather, when you go with the canine fossa approach, the incision site heals within 2 or 3 days, and there is no opening remains back. So this is about all about the maxillary endoscopy complete procedure.
I think all these extended approaches are for tumors or
the only indication like mucormycosis, you want to go in nasopharyngeal angiofibroma or inverted papilloma, where you need to go till the lateral or anterior wall of the maxillary sinus and remove endonosis. You need to go for that. Any questions till now?
for simple sinusitis, I think only winding the natural ostium should suffice as per principles of it.
So next thing is, if you dealing with the anterior disease, that the complete uncinectomy, the superior uncinectomy is important. And this, again with the ball probe and the flap probe technique, I am just everting this. And if you want to use your blades, debrider blades for longer duration, the best thing, see what I done, I dissected out this bone from this mucosa. Okay, so it takes little extra effort, so the bone is out, and what I am with my microdebrider, I just go in for this superior part of the uncinectomy. Everything with a straight plate and 0 degree scope. So this much work I am doing with the again the last bit of the uncinate, I am keeping it back to showing the importance about anatomy of the uncinate. It's a lateral attachment and everything. The way I came out, it should not happen. Actually, I am wearing the shoes. I am not used to use the debrider with the shoes. I am not tried it. So ideally, your blade should stop inside the nose and then come out. Otherwise, sometimes what happens, this mucosa gets stuck in, and you may damage this part of the mucosa, and it causes bleeding. So every time you enter the nose, your smoke gets spoiled. You come back, again need to use solution, go in, again it gets spoiled. And see, all the time when I am doing any procedure, see the stability of my scope. All the time I am engaging my scope in this superior recess and going in, out, it will be the easier and good stability, and you can operate for the hours with your left hand with this resting place. See earlier.
Basically what sir is doing is, he is keeping the instruments below the scope most of the time. And he is
in all 0-degree procedure, your scope is above, instrument is below. See, this scenario changes only with the angle scope like 70 degree, where your instrument crosses and slides above, the scope remains down and instrument comes up in the angle scope. Otherwise, in the 0 degree, all the time my scope is above, instrument is below.
when he is introducing the scope, he is retracting the skin also.
Yeah, that will be a more space here. More space. It is little step, but in the live individuals you can create more space here for introduction and avoid trauma to the nasal septum or the anterior of the inferior turbinate while introducing the instruments. See, earlier I have mentioned about the one technique using the single line uncinate. See, that's the attachment of the uncinate. And if you see here, see, it's getting attached here in the thin bone. So if I try to elevate, and if it is a too lateralized uncinate, see, here is some space, but sometimes what happens is flush, it goes in this angulation. So if it is, that is called as lateralized uncinate, and in lateralized uncinate, if I try to go in, see, my instrument is in the orbit. My instrument goes in the orbit. So this method of uncinectomy, very experienced hands, you can go for, so that is small part of the uncinate. I have just cutting. Now, another important anatomy of the upper end attachment of the uncinate, complete anatomy of the uncinate. See, we always been taught about the egg holder and the egg. So here, egg is not there because egg is your agar nasal and the egg holder is your uncinate. So I am with the 70-degree scope now again. See here, middle turbinate, the anterior attachment of the vertical segment of the uncinate process, and see this. See here, that's my uncinate, the upper part of the uncinate. This is the uncinate bone. I am slowly taking it off. So that goes and attached to the lateral wall. That's your lateral wall cells. That is lamella papillaris here, which separates your instead of pulling that in, so that may strip off my mucosa there. Go back and remember your frontal recess anatomy. The frontal recess is that was the intensity here. that the recess from here to here in the whole thing is the frontal recess, and this anteriorly limited by anterior face of upper mesa. If upper mesa is not there, the superior lower part of unseen. Posteriorly by the anterior face of uvula, that is uvula, we are going up towards the skull base. Here is a very thick bone that is called as a frontal beak, the frontal process of the maxilla. Medially is your middle terminate axilla. So if you are working between the frontal beak and the middle terminate, so you are safe. You are not going to enter the skull base. Anyway, if you go laterally here, lateral to this beak here, you may go and enter the orbit. If you go medially to the middle terminate here, you may land up into either the anterior or middle cranial fossa, or may damage the cruciform plate there. So your working limit should be the frontal beak and the middle terminate, and while removing this uppermost part, if follow this frontal beak, and you will be something called as the recess, that is your frontal recess, not the frontal ostium. Frontal ostium will be little higher up in that man.
That what you are seeing is a candlelight appearance just above the medial canthus of the eye. As I said in the morning, the candlelight will only come if you are correctly in the frontal sinus. But if you are in any supraorbital cell or any other interfrontal cell, the classical candlelight won't come. I think unfortunately sir had only one camera here. दोन कॅमेरे असते
this skipping of that should not happen. So that will be what where you are landed in the frontal sinus. So there is always fear about the frontal sinus and working in this area, but if you follow this landmark of the frontal page, follow it out, it will take you to the frontal sinus. And don't try to go immediately. If you go here immediately, definitely you will land up in the lateral lamina of the cranial plate and the may cause CSF leak. So this is something, see, during this thing, my entire face of the bulla is intact. And what Sastik talked about, opening the frontal sinus with the intact bulla technique, and till now I am not seeing my anterior artery vesicle, because the anterior face of bulla is much anterior to the anterior artery vesicle. So you are not exposed anterior, and here you got the osteo. The widening of this osteo, usually this is don't do widening now. Instead of knowing the level of the skull base, if we don't know where the skull base starts, whether it starts at this level, or this level. So for that thing, before going for widening of this frontal sinus osteo, you need to go from the behind, identify open the sphenoid, the posterior sphenoid, identify the skull base posteriorly and place it anteriorly, and then do the widening procedure in this when you want to do a full house space. If you are dealing with only the anterior pathology of the frontal sinus, matrix sinus, your ethmoid and sphenoid are absolutely clean on the scan. This much procedure is adequate. See this. And during this, all mucosa is intact, so there is no cicatrization. If you start, even you did not go for any type of nasal packing in this procedure. If you are precise with your cutting the mucosa, just pack the nose for the 10 minutes with the adrenaline packing, and that will cause the hemostasis for you. And just start the nasal pushing on the same day to the patient. By the evening, start the nasal pushing, and the things will be in place very well. So I will stop here with this anterior part of the dissection, and I will pass on the scope and the mic to the Milind. Is my teacher during my residency days. We used to go to the KM hospitals to see the cases, and he will take over and complete the dissection of the posterior part. Thank you Nilakhe Walawalkar for giving this opportunity. It was a great pleasure. And Prashant once again.
Hello, sir. This is a wonderful dissection, wonderful demonstration. And you said the frontal sinusotomy for isolated disease of frontal sinus is enough in isolated cases.
Yes, sir.
But my personal experience varies a bit. In few cases I have done a similar type of work, maybe that was inadequate, but I felt I have sufficient treatment of the frontal sinus. But the patient ended up with stenosis over a period of time.
Okay.
So since then, I thought this clearance of the anterior cells is equally important. And since the time I started practicing that, removing the anterior and clearing the anterior cells, the chances of stenosis are less in frontal sinusotomy.
So,
Bit of a difference of
I want to differ on this. If you are there, as I mentioned about the maxillary sinus, same thing with the frontal sinus. The what type of pathology you are dealing with. If it is a simple sinusitis thing, so they say the anterior face of the bulla is the draining mucosa for the frontal sinus. And if you take out the bulla, yes, then you need to go for the full face and widen it. You can go for it. If you feel that you had just open, see here the opening becomes wide because the anatomy was favorable. There was no any frontal cells. If you are here, if I encounter with a type 2 frontal cell or type 3 frontal cell, then as you are saying, in those cases I need to go for the taking down the bulla, then opening the supraorbital recess, check for the anteromodal artery, whether it is in the skull base, and by looking at the anteromodal artery, I try to widen my frontal os in those cases as much as possible. In those cases, definitely yes. Here, the anatomy was very favorable. That's why I say this is the complete procedure. So that again, your decision is from your CT scan reading. You need to go to scan reading in detail prior to the planning. So tomorrow we are having live surgery. At the same time, we will have the scan reading, the preparation part, and everything. Here now only the demonstration thing, how you need to go for handle the issue. That's the thing we are doing. I just pass on the mic to sir.
Thank you to Dr. Nilakhe sir once again. And now Milind sir will take over the dissection. As Sachin sir already said that Milind sir is a teacher for all of us, and I can say that the first cadaveric dissection workshop that I attended in my PG first year was Dr. Nilakhe sir's workshop in Kolhapur, which we did at DY Patil Hospital. And that was the first time in 2012 I think that was.
My I really thank Walawalkar Institute, the Department of Endoscopy, and ENT is really a very nice body and very good embalming technique. I hope they get the patent for it. Yes. They are applying for patent for this. I think that will be great. Okay, coming to the dissection, Sachin has done an excellent job. You know, as Sachin, there are a lot of students who have been doing such good. That's why I am enjoying just seeing them. I just, Sachin, whatever you demonstrated, I just give them some additional tips the same for There is Sachin showed nicely how to widen the medullary ostia. Now in that only one thing I will tell you what happens is, if you go little inside and go like this, so instead of opening the ostia, what you open is the orbiting. So you have to be careful that when you are opening, you forcing this lateral and then you open and then you widen. Otherwise I think this is an excellent dissection of maxillary. So the widening here, do you want to use divider more or not divider more? I can do both. So this widening, I personally do a little more because sometimes I have seen that if you don't widen enough, then you still have some collection of fluid here in spite of a big opening. You have to be careful for the branches of the spinoparietal. If you go too posteriorly, then you might encounter the spinoparietal. An excellent dissection here on the frontal. As you can see here, now I am going to frontal with 0 degree. This is not a 70 degree scope. Okay, so even to 0 degrees, because nowadays 0 degrees are wide angle. So if you are a beginner and you are taking just one scope, thinking of the particular sinus, you may not be able to operate in child. This is a zero only. See the eye pupil, which plate is this? This is the adult plate. But sideways, this is not the, this is the right side, this is not the left side. Take look like that. That here, come first. That is the right side plate. See the plates also they have on the right and left side. That is the right side. No, the one which was that. Right here. That's not cutting in front, that's cutting on the right. Fine. So I would prefer to clear the axilla a little more, not for the clearance of the disease, but a better clearance post-operatively. When the patient comes post-operatively to your OPD, you should be able to clean them without much pain. So speed coming. Then 5,000 increase 7,500. Good. Irrigation लावलं नाही. पाणी खात blocked little less, nothing else. And so if you see that what I did in the setting, somebody requested to show the setting here. This in fact I thought will show you in the surgery tomorrow, but anyway now I'll show you. So this is 7,500. Oh, light. You can see that the speed is 7,500. That is the highest speed you can get on this machine. On the right side, you can see this setting where you can set that maximum speed. We don't go beyond it. And irrigation. Irrigation is 20. I usually prefer little more irrigation, about 40 to 50. Now you see on this circle here. Do you know what setting is that? The setting is basically for your plate. Somebody just place that flower. See, rotate. If you can notice just press. Now this is because this is basically for when you are using, especially in children or very narrow noses. In fact, when you are operating, while inserting you want it closed, but just stop. Okay, you want it closed. That is because if it has a suction and I will inside, if this is open, then this will damage the mucosa. So to avoid that, always make sure that you are in a closed position. Now this particular machine, IPC, has the advantage that if I press the switch now and rotate, if I leave it, it will stop in closed position. The position which I have set, it will always stop in that. So you should always try and do this in the closed position. Now it is closed. Now as many times only disadvantage now if my assistant has to clean with the brush, he has to detach the blade, get it opened up and then put. That is a disadvantage.
So this is possible with the Nexa also.
Sorry?
The other machine, the Medtronic Nexa.
This is Medtronic only, IPC. Only this machine has the setting. IPC 3000 doesn't have.
The Nexus
That will stop anywhere. It doesn't have the setting only.
sorry, Nexus is something in between 3000 and this one. Medtronic has one more machine.
Correct, the small one.
Yes.
That also doesn't have. In fact, if you ask me, that machine is lower than IP or your 3000. But now they are selling at a higher cost, a small machine that has very few settings. And if you notice, almost have 5000 is the maximum speed. And this has 7500. And that makes a difference in surgery.
Even otherwise, in the practice, we learn while introducing, we have to always see that the blade is in the close
Yeah,
fashion.
so now alternative to that is what your assistant can do every time you are introducing, he has to film the suction. So if you have the previous machine, tell your assistant to film the suction completely. When they do it for one or two cases, they will know that when you lift that, immediately film, put it inside, go to the side, and they will start. And how does it matter all this damage? It doesn't matter today. Right now you may have a little bleeding, but that gives a raw area, and that is how if an inexperienced surgeon is operated, you can easily make out, because these micro damages would cause adhesions in the long term. So patient comes after 6 months, you see adhesions. You will feel I have done a good job, and why patient should get adhesions? This is one of them. So we have given in this scope wide outline that the frontal sinus nicely opened up by okay, here you can never use the straight blade. You will require 40 or flat 40 or 60. These partitions you can leave it alone because they are training separately. This is an incomplete partition of the frontal sinus here. If easily comes out, then it should be, otherwise you can leave it. Okay, I can easily take it out. Without even mucosa. Okay, that is bulla inflammation. You are going to get a Caesar or something. Caesar. There was a Caesar in that. See, for this part, you have either Caesar, but you have to limit it because if you go into pure, you will have more bleeding from the spinocerebellar. You may straight forward now. Since it is right in front, it will be easier to do with the straight forward. I can do with the divider. Show you I have to do straight forward. Let's take from that, blade from blade I take the straight one. So you have different ways of hitting the bulla. Either you can open with a suction, give me a straight suction. So that is the same way. While you become experienced, all this whatever is done can be done with the motorized instruments like the devider. So, as you notice, I am controlling my hand movement and just opening it gently. Don't push it too much. Now, whenever I am doing any surgery, endoscopic sinus surgery, 2-3 things I tell you. Just give me a water. Try to keep turbinate all the time, maximum time at 12 o'clock. Okay, so unless I want to see inside the sinus, I make my job as a difficult. So with a through cut, now through cut I will show you both ways how it can be used wrongly and correctly. Now if I have a through cut, I put it like this is wrong. Because I cannot see the tip of the bush. I have to see the tip and then play by it. So you are the chances of any complications. If I will take a upward forceps in the end points,
Sir, if the life is nice with the debrider, why not to go with the debrider? Because ultimately we are looking for the best of the results. And
no, they don't have debrider.
but they will have to have. They will
Correct.
have to face.
It's like debrider. That is what I said. It's like life my life difficult. Let's take this. I'm just showing them when they use the instrument what they should be careful about. Okay.
They should always try to hire one debrider.
Correct. But some of them are resident. Their bosses should give them debrider. एक है upward variable state दिला upward 45 I just want to show them something in the upward. When you are doing upward forceps, not a very good angle, but find the 45. So when I am doing upward forceps, always see to it that you are moving in this direction and not in this direction. That is the wrong direction. They will definitely open the organ. Just 2 days back, one of my residents had opened the organ so badly that I had put the melocell there, put the by the time I reached it already opened it. So I put a melocell in the orbit, a small piece, and then give the rest of the face and then move it. Because otherwise there is no way of moving the face. Up, straight forward. No, why? No, why do you have to decompress? It was accidentally open. No. Again, here, I always record that the cutting is at the top. Cutting of my blade is at this length. Perfect. Right. Right. Okay, and in this big closed position as I told you. So that when I am inside, with my finger I know where my cutting edge is. Not that I am not trying to look for. My finger will tell me where the cutting is. If I keep on changing every time I have to see. So all my blades, if you see, go I see like this, cutting like this. Even if it is adenoid, it will go like this so that my finger tells me where my blade is. What I am mounting is the pulla, and we are clearing the anterior quadrant space. All of you have been, referring to the new spot now, but previous one used to say anterior middle and posterior where we were residents. But afterwards that concept of middle inverted cells is gone. Now anterior and posterior. I was resident in 1992. Middle age you see that there is the one same, but then finally that concept is gone.
Basal lamina is the partition.
Sorry?
Basal lamina is the partition between anterior and posterior.
Basal lamina. It's a ground lamina.
Ground lamina, yes.
Ground lamina. Behind the ground lamina, you see the posterior partition. Now, when I am cutting also, if you notice, I will never put my blade like this because here I have orbit and here I have terminate. Here I have move of the deep point. So I have to be seeing all the time attachment of the terminate. It's in 12 o'clock position and then I go from down up.
Sir, if at all you want to widen the frontal pieces,
Sorry?
that which more will,
I think.
if at all if you want to widen the frontal pieces, whether will
have a limitation. Medial will actually go through your limitation. You have orbit and your skull is there. So you whatever you have to it has to be anterior. In fact, now what I do is we don't have it here, but if you have seen there are some punches which are like 45, like for the frontal beam, and with that you can widen it enough.
Even if it's needed, even the drilling part,
But the widening which is done in here is good enough for sinusitis case.
yeah. But if it is stenoid, and you want to widen it, we have to do it anterior.
Yes. You can go from here. You can remove a little more of axilla and then you can do anterior. Just give me a plate and straight the plate also. Straight through.
The important structure what we see on the posterior wall of the frontal is again a vascular structure, the anterior ethmoidal artery.
That's not the anterior recess. That you will see that the frontal recess, you will have one shape and after that you will have the artery. I show you that. Give me a photo. As you come closer to anterior artery, prefer shift to hold instrument rather than depress. Most of the time you see, but it's not that every time you see. Give me a period. No, load period is not. I give you one from that trainer that I require to know. Partition in the frontal recess. Give me a straight period now. Usually it is 6 mm, 6 mm. Give me upward motion. Here you should have that. Can you see that? That's the active for that. Both in the orbit now. In surgery, we will be able to show you much better because it has a flow, but here also you can see quite properly. Possibility of variations are there, that's what I said, that every time you may not see the impression, but that you have to diagnose on the CT scan. On the CT you will know whether it is running very low or high. Also.
Once we are working in frontal disease area, it's very important.
Yeah, see now I know what I was telling you, sir. This is anterior artery, this is the frontal region. Usually after that you have at least one or two cells. After that you will get. You don't have it exactly at the front.
The cell just below the
This is the most important. Sorry?
The cell just below the fundus sinus, is it still called supraorbital?
No. Supraorbital, this patient doesn't have, this body doesn't have supraorbital. That will be almost flat, parallel to the frontal.
Okay. So this will be called frontal dissection.
frontal one.
Yeah.
Straight force.
Very beautifully you can see that artery.
Yeah. If I have lesions here, then and I feel that I need to clear lesion behind the anterior artery, then I usually prefer to just take a bipolar, contract both the ends, cut it off, rather than pulling it. In forces is not possible.
In extensive polyposis cases, so this area we have to be very careful because sometimes the artery will be, as in this case you can see, very nicely delineated and inadvertent working with the divider or maybe with the instrument, we may injure the anterior ethmoidal artery.
So if you injure the anterior artery, what you will have is a orbital hematoma because of retraction of the orbital end of the anterior artery. Into the orbital end continues to bleed, and now it can happen on table. It can be used this portion is not holding at all. Some instruments are absolutely wrong. There's so much of gap, or it's not clean, I don't know. It's not the correct concept of use here. Then the article diagram was that. I don't think so. Then that will not be article. Give me on. That is what I said, that in the light you see better. This is what it is. Great. Other one. That is not the article which I showed you. That is what my was asking whether there will be variation. Now you can see this is quite touched onto the sorry. If there is an injury, then you have to see patient as a hematoma. Then obviously you have to apply to the comprehensive immediately and apply ice and surgery you can continue provided the hematoma is under and you have to see for the pickets that it is reacting well. If it is post-op, what you will see is the patient will start getting blur vision, then we will lose the color vision and there is a loss of vision. And all this happens in 20 minutes. There is a rule of 20. 20 ml of fluid in the orbit for 20 minutes can give you complete permanent blindness. So you have to be that quick in knowing if it is there. So we have opened the anterior and posterior ethmoidal cells. Now we need to go to sphenoid. Now for going to sphenoid, you have different options. You have an option of going from here, where you have to go to the last cell of the posterior ethmoid and go intermediate to open. This is one. Second option, if you are too scared, then you go medial to middle turbinate. You can see here the superior turbinate. And there you will see that frontal sinus. Can you see that? That the opening of the frontal sinus, which you need to widen. The sphenoid sinus, which you need to widen. Okay. Now widening you can do different ways. If you are very experienced, you can do with the divider or then Kedison punch. I will show you from here also and there also. So if you are using a divider, again the cutting should be
inferior. I say I am having the same problem like India. Which shoes can cover anything? Sections are there. So it is inferior, okay? Now same thing I will show you with the punch. Give me a punch. Sorry. No, that's it. So ideally you should have a downward punch. So downward and 90 degree. Now this is 45. 45 degree is the cutting edge is 45. So ideally I should have a 90 degree downward. But since we don't have, I will show you how to use it. Downward will look something like this. Put one edge inside. Go inferiorly and wider.
For this, we can also use mushroom force.
You can use mushroom, but mushroom the problem is they break very fast. You have mushroom here. Straight mushroom. You have two types of mushroom. One is straight and one is giraffe type, which is for the front. Now mushroom type is basically a type like this, which can cut all around. Now again this whatever is good cutting as Sachin told you, it's only given in the past. Local made will never cut like this. Sorry. You have a septal branch there. If you widen it quite a lot inferiorly, then you will come at all. Again that is variable, and even if it bleeds, it is quite easy to control with even a monopolar problem. Can you see the sphenoid? Yeah, inside the sphenoid. Now the same thing.
Sir, one request. Can you just give us an idea of Hadad flap, the pedicle of Hadad flap, as you are already there?
Yeah. So Hadad flap is basically, give me a ball. So it depends for what you want to use it, correct? If you want it for a figure, those are pedicle flap. So if you want to use the figure Hadad flap for a figure defect, then you need to start here, elevate the septum, go like this, and then raising the mucosa and rotate this flap upwards wherever it is.
So in relation to the sphenoid sinus ostium, I want to know.
In relation to the sphenoid sinus, sphenoid ostium will remain down.
Okay.
I don't go near the sphenoid at all.
Yes.
I do the flap like this from here,
Okay.
and rotate it, leaving the sphenoid sinus down, and rotate this flap.
Okay. Yeah. Thank you, sir.
If the Hadad flap, we require it for closing the roof of the sphenoid and pituitary, then we can go up to.
Yeah, then you rotate it inside. What pituitary we will rotate it. If you have a CSFT there. You can see this, we are opening from the ethmoid. So we went to the last important cell, then you don't go straight, because then you hit skull base. You want to go inferior.
Feeding artery for the Hadad flap will be the branch of the Nilakhe.
You make a recent punch. That's the optic now. Can you see the optic now? I will point it out.
Yes, sir.
Not coming over the lab. I need a pointer or something. That is too much of progress not going. Okay, now when you are punching from here, again the thing is don't go on to the optic nerve here. Don't go much up. Go medially and inferiorly, which is the safest to widen.
knee, long parts, okay. Straight pivot, give the straight pivot. Pivot, straight. You can use a pivot is one of the same instrument for this skin party. Whether here or in the latina or wherever.
J. Curette was one of the favorite instrument of Professor Stanford.
Yes. In the frontal recess, the anti-inguinal which we have missed first time. Here somewhere you should have posterior, but that does not give you the full impression usually on the bone. And then you have the optic nerve. If I can see a carotid bulge, I will. That the carotid optic recess. And here we have the bulge, so even though it is not very confident in this particular patient. Now we don't have the CT scan as such, but otherwise sometimes you may have that the other spinal actually open from here if the partition is incomplete. And you may have sphenoid on one side very big, on one side very small.
So can you show the landmark for the median now?
For the median, see where I stop. For the sphenoid diagram, that you will stop here. For the median now, you will elevate this and then go onto the sphenoid diagram and then you get that. But median now, median during forming, now I think almost is given up worldwide. But doesn't it give today morning or yesterday when somebody said the message should have to I said no, don't do it. Doesn't give good result in for the one dry eye because of main indication point. There are a lot of publications now. If you notice, there is no article saying about here. Forward.
Rather than going for median urectomy, posterior urectomy helps. Let's say we are doing one study at Bharati Medical College. In cases of allergic rhinitis, the inferior terminoplasty and posterior urectomy results comparison. Till now we are happy, at least for the initial phase, but long-term follow-up needed.
So before we go to the DCR, I wanted to elevate this for the sphenocarditis. In cases of epistaxis or so, if you are bleeding from here, then you can go. We have to remove some bone. You just take the blood.
On the perpendicular plate of palatine bone, and right there you get a groove and the artery coming out
left particular. Now this what I am doing is also done for angioplasty. Left periosteal. See here, because tomorrow I think they are not in routine. They will be watching somewhere or inside though? Inside though. So because I wanted you to see that how to keep this left hand steady. Because I am not keeping it steady, even if I look there my hand will not move. That is because I am using, think of the nose as a fulcrum. So this support, I cannot show it.
I show you. This support, I will never leave. My scope will be always, can you see that? It is always resting against the wall. It will never be like this. The moment you try, I see a lot of videos that try to do like this. The moment you leave this support, your hand is going to move. So this fulcrum we should never leave. With that you see that the experienced surgeons, their left hand will be absolutely steady like this. You tell me for 10 minutes I will give you exact same picture as if you have taken a photograph just now.
होता ना था सेम
I prefer that with the flow because better fine. When we are doing angiopyroma, we go here and remove the complete posterior wall to expose the tumor. But for the sphenopalatine, we will just go here, remove some more. Give me a Garrison punch. Remove the bone. In angiopyroma, I prefer to use here either a ring or a chisel.
Most cases the posterior wall is pushed anteriorly and very important.
What is that sign for level sign?
Yes. But she has recently seen the double shaped tumor.
Elevator. Just blade clean के अंदर straight blade clean. Here you see the reason. That's
Yeah.
Actually the thing is sometimes it's not the main pyramid, sometimes it's the branch, and then you have to place that and go inside. Carry something like that.
Is there anyone tells how the IMAX divides in the pterygopalatine fossa in the resident?
It will not get engaged. You require basically a chisel. I want to just remove this both, but I can show you the vessels variously varied. You can see the vessel. Can you see that? Now you want to see the DCR or can I do some puncture or what I want to see? DCR also can be. You have any blade, cutting, 15 number का ideally I take the incision with the incidental ball. Tomorrow do you have a DCR for surgery?
Yes, sir.
Then I take it. But here I will blade I can take 12, 15. This is now I just for Cadaveric I will use that, but otherwise I don't do it. With knife I will do the parting. See, this is the uncinate process already removed from here. This is the area where you have the lateral sac, and the body projection here is called the lateral correction. You have a dialectic incision with this. Now dialectic with this. This is not a very fine incision, but main work what I want to show is the full work. Okay. When this is intact, the flap remains like this. You don't have a hole like this. This is because uncertain time. And tomorrow, as you will see, the flap I take out at the end, so that you protect the middle terminate from your instrumentation. Now, after we do this, we always try to press from outside. Here, you will not see in the. You can see some movement in the center. That's because I am pressing the sac from outside. Now, eventually, remind me, I will show you how to differentiate whether there is a sac or a short beat. Here, difficult because too hard. But when you press the orbit, you see the movement much behind. Where if you are doing a DCR, this won't be exposed, right? This is exposed because I have done the dissection behind. But otherwise, you should see only movement here, not on pressing the orbit. You make any sense. The incision part can show better on the surface. When you are using a punch, use like this and start removing. Once you remove a little bit of frontal portion of maxilla or a lacrimal bone, you should be able to see a better movement. So go on removing this without opening the sac till the attachment of the terminal, where approximately will be the opening of your common canal filament. Here again we won't have a floor point. You can see the here, if I press, you can see the sac ready. You have 9 now, 15 number, 12 number. Ideally I require a 12 number, but you are in 15 is okay, 11 is okay for opening the sac. 9 number simple. I don't open with single because single is used on the board on the unseated. So it's not very sharp. We put in the 12 number plate or some, so that you look at it. I take a 12 number.
Because consideration is already done, maybe exercise is facing some difficulty in that board. Otherwise,
Can you see the sac now?
yes.
Now, if you notice there is some part of the lacrimal bone still remaining. I will show you where. Give me a minute.
Otherwise, if you come along the infundibulum, you will just get a small defect.
Can you see this? This thin bone
Yes.
is a lacrimal. If you go much behind, then it will be a lacrimal. On the other side, this flat has a C shape. No, only that. And then recall it here. So I put it here at the end I cut it out. No, I won't prefer that. I want to show you I cut it out before. Even if you put it like this, it doesn't stay there. It moves and knocks the opening. I can show you the standing technique also tomorrow.
So for the flap to be repositioned, do you give a cut in the middle and then place it over?
I will place it back, I remove it because it doesn't remain very good. And that is the cause for failure in something. Not all, but I will say 50%. If it is a revision or a post-traumatic, then you have to now this press, we have to make sure that the sac will be open and not down. Again, that is much easier in the if patient has a bacteriocystitis, because in that case the sac is widening here. Okay, that's the sac. You are not seeing any fracture now. Now you don't have to stop here, you have to go right here up. Again this medial wall, I prefer to cut it off, I don't keep it with the scissor. I have specialized scissor with which I cut it off and then put the stent in it. During cadaver, you cannot see a sac opening like what you see in the film. Sachin, you want to show something? What they want to see, I don't know. What is the time that is right?
Sir, can you please show where exactly you open to approach for a peripheral fossa?
Further?
For the angioplasty.
Angioplasty. You see almost done the lot of it. Various millimeters. For the angiofibroma, you have to remove the posterior one. So what I remove is I usually remove of this mucosa. Give me a photo. In the angiofibroma, the difference is the posterior wall is very thin. So sometimes just with a cadaver or a fluoride, I can easily break it up. Can I do the No, you are asking for angiofibroma. In angiofibroma is not a functional endoscopic sinus. It's an extended indication. After we remove the mucosa, depending on the extent of the tumor, you can escape in 70 degrees. You have to start taking the bone from here. Something what they won't see tomorrow is external frontoimplanectomy many of you want to see, but here there is no external cataract. So I have to remove the bone. Suppose the tumor is still here, then I need to remove the bone at least till there. So starting here, you make the result.
Chisel out, sir.
Chisel out. Chisel you are. Chisel hammer you are. So article 70 degree with the 70 degree actually go much flatter.
The most important thing, stability of your left hand, the way the sir is holding.
Yeah.
With hard lateral you make.
Can you see this? Now the bone you can really lift up like this. Much release and less superior. In the angiofibrom, because there is a tumor behind, with which the bone has undergone a little of pressure necrosis.
So in angiofibroma, as soon as you open the endoscopic fossa, the posterior wall of the maxillary sinus, you see the angiofibroma bulge coming out from the fossa.
That is infradiagonal fossa fat. And once you see the fat, that means you have gone beyond the tumor. Many a times you see a IMA. I do not know whether. In the angiofibroma, what happens is medially. So you see it much easily. You can usually have clamp or tap. Wherever you can see the vesicle. Also. So you can easily apply it with a quick applicator, either size 100 or 200. The click here, even sometimes the mixture is not available, and pass a thread through this and tie. So you can take tie on this side and this side. No, I do all endoscopic after, but still if you tie it, it will always.
Now I have 25 angiofibroma without. Earlier we talked about extended maxillary sinus apparatus. With a zero, thank you Vinishal, very nice demonstration. The sphenoid sinus, I just want to add one point here with how to identify whether you are in the posterior or the sphenoid. Most important simple thing when you go in, see here, you can't see the floor. You need to advance and the floor is much lower level. That's the most important thing in all posterior that already is gone. But if you see the posterior, you can able to see the floor, the end of the cell. But when you are in the sphenoid, you cannot, you are much higher level than the floor. Unless and until you take down this rostrum, you can't reach the floor. So this is the most important step. Lateral approach, intermediate approach, and medial approach. So these three approaches you can go for the sphenoid sinus. Talking about the maxillary thing, initially I talked about the modified endoscopic. modified Denker approach where you need to take down the anterior and so we need to take down the part of the anterior wall and the medial wall of the maxillary sinus. So the incision for this modified Denker's approach. See, original Denker's approach they introduced the subrachal approach like your Cadaveric going down and taking down and do this thing. With the advent of the endoscope, now we can do everything transnasally. So the site of the incision for your Denker, you need to go at the level of the piriform aperture. See, I move my prayer slowly laterally and you can see the pipette kind of thing. See, that's the anterior end of the piriform aperture. At this level, the best instrument to take this is your populator. Now this populator is doing and helping out excellently in cases of this endoscopic sinus surgery. So if you don't have any sharp instrument, see that's the level of your piriform aperture. And when you take incision at this level of the piriform aperture, you should always should be sub-periosteally. If you won't go sub-periosteally, if you elevate the plane above the periosteum, there are chances that at later stage this may create fibrosis and subacute. So if you go sub-periosteally, less likely chances of elevating, causing the external scar and depression. See, now I am advancing and this is a cadaver. Here you may encounter some bleeding. So that's why I said populator is the best tool to do this part of the dissection. Moment you are in the plane, you get a vascular subperiosteal plane and go laterally. See, it's a little stiff here in the live, you get easy elevation. Again, the limit, how far laterally you need to go here. See, knife so see here, there is a very important structure you see which comes up from the anterior wall of the maxilla, that is your intraorbital bundle that comprises the artery, intraorbital artery and the nerve. The one coming down is the artery and that is the nerve. So this anterior wall elevation should be short of this intraorbital foramen. So you should not damage this, otherwise it will cause paresthesia of the malar region. So you need to short of this elevation, don't go to that level. So this much elevation is adequate. So this part here you need to go for the osteotomy. Either you can use the drill here, but you need a good expert assistant here which can hold this periosteum and you are using the drill, because there are very high chances of damaging. See this piriform aperture? Have you understood where I got? This is the nose. This is the piriform aperture. This is the inferior turbinate, that's the medial wall. See this? That's the inferior pompal bone attaching to the maxillary bone. I am just elevating the inferior turbinate now for the better understanding. You see that's the inferior turbinate has been elevated all along. Okay. So that's the medial wall, that maxillary process of the lateral wall, and here I made the fenestra of going to the maxillary sinus, that is inferior androstoma. So that's the medial wall, that's the anterior wall. So I need to take down both these things to complete my modified Denker's approach. So here I am going with the osteotome.
routinely also I prefer to go with the osteotomy. It's an easy, fast procedure that less likely chances of damaging your scope. With the drill here, the chances of damaging your yes. The superior limit for the level of the superior tinkers is at the level of the orbital floor. Yes. See now, this is my anterior Walawalkar. I will come down now. See that my anterior Walawalkar is complete. Now I go along the floor. See that this piece of bone comes out as a single piece. See this. So that's my medial, that's my anterior wall, and the movement. I am not completely holding avoid damage to the sinus. See now I am in the maxillary sinus, band 1. Okay, see I just take down this mucosa a little bit. Understand it better. See, that's the thing here is the maxillary artery. We are going this path laterally from here, but when I open this approach, I can go in and do the instrumentation. See this much, and with a straight arm. So if I open this part, I'll be in the infratemporal fossa, that's the pterygopalatine fossa, that's your IMAX here, already been demonstrated by the Millin sir, which divides here, inferiorly gives the greater palatine and anteriorly gives the spinopalatine, which enters the nose to the spinopalatine foramen. Greater palatine goes down here in this canal. Tinkers and modified tinkers. I mentioned that thing actually. See, the tinker originally described this approach by the translateral approach, going from the upper pneumovocal circles, elevating like you elevate for the calculus procedure and do this osteotomy. But with the advent of the endoscope, what modification we are going at the level of piriform aperture. See, here still my superior cut is here, but this fracture happens at this stage. And now that the sir has demonstrated your lacrimal apparatus here, so by elevating I will show you the better lacrimal anatomy. See, give it a normal.
nice cadaver. Whenever people say I'll stop. See now, see, that's your lacrimal sac exposed here, and that's your, what is coming down here is the lacrimal duct. Okay, that's the lacrimal duct which opens over here. So, with the Caesar, I usually go and take this cuts. The superior lacrimal cut should be sharp cut, cutting the sac right there, and you can knock down your inferior turbinate. Here is the hold the lux and nectar. So now see, it's a complete medial wall, the nasal cavity. Down here. This is your complete medial maxillary. Okay, so that's the posterior wall of the maxilla, that's the lateral wall. With the 0 degree, I can see the anterior wall, and that's the maxillary floor, and that's the nasal cavity. All the things are getting connected by the extended approach of the maxillary sinus. Anything you people want to see other than this? Anyone's interest? So, while so when you're working on the floor, skull base, so here, as I mentioned, you need to open the maxillary sphenoid sinus wide, and that's the planum sphenoid. And this planum sphenoid, you keep following it anteriorly, 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 and again what we have opened this is at the slope. That's why earlier I said instead of going beyond knowledge, if I would have tried to widen the frontal here, I would have ended up with the foveal bone, it's quite a thick bone, less likely. But that's my level of the skull base, and sphenoid os is there at this level. So that's why initially define the frontal os. Define the frontal os. This is the frontal recess. Go back, complete the ethmoidectomy, complete sphenoidectomy, follow the sphenoid group, posterior ethmoid group, that's the fovea ethmoidalis. That's the site of maybe most likely the posterior ethmoidal artery, that's the anterior ethmoidal artery which is running like this, and then the frontal recess. That's the complete, sir had already demonstrated all these things. There's one more thing, talking about the septal perforation repair. See, recently I had done those 3 cases of septal perforation repair, and again, like the Hadar, see, you know, this anterior ethmoidal artery is branch of ophthalmic, is a part of the internal carotid circulation. So it traverses from lateral to the medial, again enters the middle cranial fossa and re-enters the nose and comes down on the septum as a branch of anterior ethmoidal artery supplying the septum, and that is roughly 1 or 2 millimeters posterior to this axilla, so at this level. So when we are planning for this septal perforation repair, so we can design flap based on this anterior ethmoidal artery. So you just take the cuts till the posterior end of the posterior end of the septal perforation. Extend this cut. So I need to elevate this flap like this. Extend your cut down on the floor, and similar you need to take a posterior cut coming down the floor, whatever the length you want, and elevate this flap, rotate and suture it here by pressing the anti-edge of the perforation and posterior edge, suture it. In between, transport the temporal fascia and you get a good results with this. So that's the most thing I required. Sandeep, you asked for the hadar cut.
Yes,
So
sir.
sir has already mentioned. So that is sphenoid os. Okay. So that's the superior border of the foina. So the inferior cut should be at the superior level of the foina and coming forward. And accordingly, how much is your defect you want to repair? Either you want a larger flap, you can go on the floor and come forward, or you can turn this incision coming right till the anterior end and elevate it. Similarly, the superior incision at the level of the sphenoid arch, just 1 to 2 millimeters below the sphenoid ostium, take this incision right coming anteriorly. Okay, till the level of the turbinate, and then turning the incision upwards. And that why like this? Because here you can preserve the olfactory neurons or olfactory mucosa. If you are doing it for the pituitary, so you can preserve the olfactory neurons by doing this manner. And you can decide how much pneumatization of the sphenoid and defect you want to repair. So the pedicle usually shows that the septal branch of spinopalatine artery, see here already we had spinopalatine. If we place this artery here, that comes your septal branch. So that's the pedicle for this hadar flap. So it goes like this. The disc flap here, instead of raising the hadar, if you want to do the pituitary and you see only the tumor is not extending supradiaphragmatic, that the cellular tumor, then in case just take this flap, take down this mucosa causing the posterior secretectomy, go in, finish the work. If in case you encounter the CSF leak while pituitary surgery, you can raise this flap and put there at any time. So this is called as raised flap. So these are commonly used flaps. Again, you can elevate the flap from the lateral nasal wall. That in some cases of gestational neuroblastoma or all, where usually this tumor extends down and involves the septal mucosa mucopericordium. So this hadar is compromised in those cases. In those cases, this spinopalatine based lateral based flap can be used for repair of this sculpus. I think almost we have told. Only thing we left out is the drill out procedure. There is something called as axillary flap technique. See, most of you are not well versed with using the 70-degree scope. So if you are well versed with the 0-degree scope, so there is a simple technique where if you want to work in a frontal recess area and you want to use a 0-degree scope with a straight instrument, so what simple thing is you can go for the axillary flap technique. See, this is the axilla. Go 3 millimeters above the level of the axilla, and with the 15 number plate, take this cut and turn this cut down. If we are not having any plate here, if we are tomorrow in live surgery, I can show you that this simple flap will be elevated here. So that's my part of the frontal tip, and I am doing with the 0-degree sequence. So slow Carison punch, go in here and just take down this part of the frontal peak. Okay, this is a straight Carison punch. I need third or something called as articulated Carison punch comes. There are multiple joints and intervals, so that will help in removing the maximum part of the frontal peak. Okay, these punches are again from the stores, car stores or the Medtronic. They cut the bone like this. The Indian made punch never cut the bone like butter. You need to struggle with this. That's the make of these instruments. See now, my straight chairs, straight instrument, 0 degree scope, and I am going in and see the level and see where I am going, where I reached. With the right in the roof of the frontal sinus, I can see with the 0 degree. Okay, I need any angular scope, and here after the procedure simply deflect this flap like this. So if you deflect this flap like this, that will prevent the fibrosis in this area which causes the turbinate to move like this. So this will go and keep the pack here, keep the pack in this pieces, and that will help in your douching of the frontal sinus when you are doing this for the AFS cases. So this very nicely 0 degree from here sphenoid transition to the frontal sinus.
Yes, sir. It's a very important step in fact, because it will avoid formation of granulation in the pain area. The repositioning of the flap what sir is telling about is very
It
important.
is designed by Peter Woodman. He popularized the axillary flap technique.
Sir, can you please tell us something about studies what you are doing for allergic rhinitis?
Pardon?
What you do for that?
Pardon?
So the studies what you are mentioned, studies
Allergic rhinitis.
for allergic rhinitis. And what procedure?
Damage. This thing. See, in the we'll go for the inferior turbinoplastic technique. So what we usually do either with the microdebrider, just medialize the turbinate. Okay. Most of the time it will get the most hypertrophic state of the inferior turbinate. So by preserving the superior surface of the inferior turbinate, you can eat out the posterior third of this inferior turbinate. See, this much of the mucosa you can just debride it out. We are having hot. Always when we do the cadaveric dissection, there are limitations with the instruments because we can't. But see, Storrs people, they are given their instruments here for the cadaveric dissection. We are really thankful the Medicare people for their debrider system and Storrs people for this visual camera and so. I'll go and end of the inferior turbinate and just knock this mucosa off. While doing this, just take precautions, don't come too anteriorly where you may encounter the inferior turbinate branch of spinopalatine artery. If that bleeds, that artery bleeds from the bone and it's very difficult to handle this thing. So here all the time I am preserving the superior surface, so I am just taking down the lateral part of the medial surface mucosa, and after this just take the press and push it down like this. See the amount of space created here, and your anterior end of the turbinate is not touched, so there won't be any, and also the drainage mucosa is not touched. This draining mucosa is intact. After this, see that's the attachment of the uncinate. It turns and comes here. So here, if there is no maxillary disease, but patient has, you want to go for the, so that's my landmark. Here is my posterior nose attachment of the middle turbinate, the horizontal limb of the middle turbinate, and this is my site, most approximately 2 to 3 millimeters anterior to this is my location of the spinopalatine foramen. That's why earlier when they promoting the infiltration, they used to say at the posterior end of the middle turbinate you need to infiltrate, get a free congestion. So just 1 centimeter anterior to that, come here and with the 15 number blade, I just take this vertical incision. Okay. After that, slowly elevate the mucosa, medial mucosa from this bone, and go slowly subperiosteally elevating here. This mucosa, as I mentioned, it's doesn't stay like this. In live cases, it stays. As I go posteriorly, see here, I start seeing my spinopalatine foramen. See, that's the spinopalatine foramen there. See here, this is spinopalatine foramen. So down here, you start seeing some fibers, neurofibers. Along with the artery, see this, these are the, see here, they are merged. Tomorrow I will demonstrate, see this. You can see this, fibers, see this. So you just need to cut them sharp. Your artery is above. There are chances of bleeding, but even if it happens, just take the bipolar and bipolar. Again, that will help in your allergic rhinitis patient to give the congestion of the mucosa. There won't be any necrosis of the mucosa because there are not many anastomosis happening. So cutting these branches of the posterior nerve, and after this just repose this back. So that's the procedure what we are following. See, if you have populator, the simple way of doing this thing, no need to take any incision, no need to go for this. Just, this is my posterior end of the middle turbinate, that's the reflection, and just populate this part of the mucosa. It will traumatize your posterior nerves, posterior nasal nerves, and it gives the symptom. But the majority study says the symptom control is for the initial 6 to 7 months, and then this cut nerve fibers again they re-anastomose or re-innervate the mucosa around, and that will cause the purpose. So there are few studies where they are done what they are doing, they are elevating the flap, they are cutting, see that's the nerve, that's the nerve, see this, down, that's my artery above, and that's nerve.
So it's a kind of neurectomy.
Yeah, posterior nasal neurectomy.
So what do you feel? what kind of symptoms are reduced? Whether there is
The
an obstruction or watering?
mainly rhino.
Mainly for rhino.
Yeah, it reduces the secretion of the nasal wall. That's my nerve and that's my artery. This nerve needs to be cut here, and that's my artery above.
Actually, personally, even I feel whenever we are going for septoplasty, whenever we are going, whenever we are going for any septal surgery, we always we often do nasal endoscopy, diagnostic nasal endoscopy to assess whether there are associated findings. But we should focus on posterior end of the inferior tablet. That is the part which is very often floppy and adds to the nasal obstruction in cases of allergic rhinitis, or not necessarily allergic rhinitis, cases of nasal obstruction.
Yeah, that's what I say. Simply knocking this posterior third of the inferior tablet gives you a very good result.
But do you cauterize that part or not?
No, not. See, bipolar cautery will damage this part of the mucosa. See, base tool is going with the operator. If you want bloodless, even you can do as a skin OPD procedure, just infiltrate this turbinate this part and with the operator knock this out.
Then we need to be careful while we do surgical practice because patients will need a little bit more than usual.
What I am talking is left in between. There are studies where they are doing posterior neurectomy and interposing the silastic sheets here.
Okay.
And putting this mucosa back to avoid the reanastomosis. But don't know. I given this one of the topic to one of my PG resident is working on this. Let's see what results come out.
Sir, one more question.
Appellate.
So how is the selection of cases and in what predominantly what type of symptoms these are going to do in all cases?
The purely allergic rhinitis patients, this procedure we are combining either with the septoplasty and turbinoplasty and posterior neurectomy, or only the inferior turbinoplasty and posterior neurectomy. So they are basically those who have too much of the rhinorrhea symptoms. Those cases we are seeing.
Not sneezing and
Not sneezing, it's basically for the rhinorrhea, the nose symptom.
and what you do for the whole inferior terminate, you're not doing it.
Inferior turbinate bone, see if there is too much of the hypertrophy of the turbinate, so there are different techniques of doing inferior turbinoplasty. Either you can take the incision at the anti-end, like this, like Janaki Raman, and there is one electronic plate comes with this, so you can just go like this, debulking the thing, preserving this medial part of the inferior turbinate, one. Or you can just take this incision, elevate this part of the mucosa, take out the bone, and if this lateral part of the mucosa and this medial part is rolled and kept like this.
Like we deprive the lateral part of the
I'll just show. So depending on the size of the turbinate, if I feel there is not too much of the anterior state.
I feel it's a very good technique for managing allergic rhinitis surgically because most of the patients, they are not responding to medical line of treatment and they come repeatedly with the symptoms and they are so much distressed with the symptoms.
If you are in a private practice and doing this case in your private practice, see, I would suggest whenever you are going for the septoplasty procedure and having the populator, just use it for a second, just ablate that mucosa, at least for the initial 3 months, the patient is very happy with your surgical outcome. Don't know what happens after that. Definitely you need to depend on the intranasal steroids, there is no alternative for that.
Now, sir, one more question. How does this technique differ from the surgical turbinectomy, partial increase turbinectomy? What kind?
I'll show that also. See, now I removed this part of the bone and then the lateral mucosa here and just roll this mucosa back in this. See this. So that gives
Good airway, very good airway. And as sir is telling, even patients with rhinorrhea and sneezing, even they will get relief.
So you are talking about the partial. See what usually people do, they just put the artery clamp, preserving the anterior 1/3 of the turbinate. Just put the artery clamp here like this. Cut that turbinate off and put it back. But sometimes while taking this cut, see here is your artery comes.
Yeah.
See that's the maximum height of this inferior turbinate crust. At this level, your artery enters the inferior turbinate. And if accidentally your cut goes like this, and if this artery starts bleeding, other than doing the ribbon was packed, whatever particular cord is there, that ribbon can just put the gel foam and on that, if you are having surface, just a small piece of surface in there and pack it, it will stop. Yeah. Shall we stop? Yeah. Yes. Exhausted.
So thank you very much, sir, for the wonderful demonstration, both of you. And it was a nice academic piece. And also, I feel all the residents have gained a lot of knowledge, and they will acquire a lot of skill in doing the endoscopic sinus surgery in their day-to-day practice in future. Thank you very much.
Yeah, I really thank the relatives of this cadaver. They are one, by their grace we are getting the opportunity, and lastly again I really congratulate Prashant, your techniques are excellent. The cadaver is superb.